All right. If you're dialing via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their devices via Google Meet. DUR board members reserve questions until the end of presentations or asking the Google Meet chat. And those providing public comment, if you would like to provide public comment, a conflict of interest form must be on file. Please send an email to medicatepharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicatepharmacy@utah.gov. And then just a note, I typically send the agenda to the DUR board a week in advance. And so the conflict of interest form received from public commenters should be sent in a timely manner, hopefully, a week before the meeting. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. And so right now, Dr. Weinstein, the DUR board chair, is not attending, so I will go ahead and start the meeting with the agenda. And so welcome everyone. And the first item there is housekeeping. And so I wanted to announce that we, starting next week, we have a new pharmacy director, and we will get formally introduced to that director at the October DUR meeting. Also, the next item is the approval of the August DUR minutes.
Move to approve.
Second.
Thank you. Thank you, Dr. Brinton, and also Dr. Smith. And all in favor?
Aye.
Okay. Any opposed or abstentions? Very good. So moved. And the next on the agenda, we have the prior authorization updates, which last month we reviewed Kebility, Yes2Go, and SkySona, and those have been successfully posted on our website. Next item on the agenda is public comment. So currently there are 4 listed on the agenda. First, we'll hear from Carla McSpadden, a pharmacist with Galderma, regarding the product Nemluvio. And then she will be followed by pharmacist Kevin Chang with Sanofi on Dupixent. And then he will be followed by Scott Kern, a nurse with Eli Lilly, speaking on Ebglyss. And lastly, we'll hear from Jeff Martin, pharmacist from BioCryst, speaking over Orladeyo product. And so I'll give the time now to Carla McSpadden. And as a reminder, I'll be timing each speaker for 3 minutes. Carla, are you here? Are you on the meeting? Yes, Carla. Looks like you're muted. All right. Looks like we're having technical difficulties with Carla. Carla, can you click on the microphone icon at the bottom of the screen?
Hi, can you hear me now?
Yes. Yes. Go
Sorry,
ahead.
apologies. Just having some technology issues here in the airport. So thank you so much. I can go ahead.
Yes, please.
Oh,
Thank you.
Okay, Great. My name is Carla McSpadden. I'm a pharmacist employed by Galderma. Appreciate the opportunity to speak about Nimluvio, generic name nemolizumab. Nimluvio is indicated for two skin diseases, prurigo nodularis, and then moderate to severe atopic dermatitis in adults and pediatrics 12 and older. Nimluvio is the first drug to target IL-31, which is a cytokine that's implicated in itch, inflammation, and skin barrier issues. In the atopic dermatitis trials, Nimluvio significantly improved skin lesions and disease severity at 16 weeks. It's also demonstrated significant itch relief and sleep improvement within a week after the first dose, and significant skin clearance within 4 weeks. It's been well tolerated in the trials. It has no warnings or lab monitoring requirements in the PI. Nimluvio is self-administered subcutaneously using an auto-injector pen that has a long shelf life after removal from the fridge, 90 days. And it's the first atopic derm treatment dosed every 4 weeks, with maintenance dosing extended to every 8 weeks for responders. As for how many might qualify for every 8-week dosing, all we know at this point until there's longer real world utilization is that in the trials, 37% of patients had skin clearance at the 16-week mark and moved into the phase of the study that evaluated every 8-week dosing. And then even more, over half of patients have gotten clear over time in the long-term extension study. Also, Nimluvio has been strongly recommended in the 2025 update of the American Academy of Dermatology guidelines in combination with topical therapy. And so now it's in line with other biologics used to treat AD. So Galderma is respectfully requesting that Nimluvio have parity access to Dupixent and Adbry, similar preferred status, similar clinical criteria, and the rationale for that request is first to offer a different MOA on the PDL and IL-31 rather than two IL-13/4. Second would be the clinical benefits in itch, skin, and sleep that Nimluvio offers. And third, the potential value from responders extending that dosing interval to every 8 weeks is recommended in the PI, which would equal 6 pens per year for maintenance. Happy to answer any questions.
Thank you, Carla. Are there any questions from the board? Thank you. Hearing none, we'll move on to Kevin Chang, please.
Okay, am I good to go?
Yes.
Oh, great. So yeah, good morning, everyone. I'm Kevin Chang, and I'm an associate director on the medical value team at Sanofi. And I just want to thank the board for the opportunity to comment on dupilumab or Dupixent for the atopic dermatitis PA criteria review. So just some background, dupilumab was originally approved in 2017, and for atopic dermatitis, it is approved for adult and pediatric patients down to age 6 months for patients with moderate to severe atopic dermatitis. Just a couple of things to note, it may be used with or without concomitant topical therapy. And it's also approved for several other conditions, including asthma, COPD, and most recently, as of June, bullous pemphigoid. So today, also just wanted to highlight a couple pieces of longer-term evidence, since this has been in the market for several years now. First, I'll highlight the PROS registry data, and this was an observational study of patients who were treated with dupilumab in the US and Canada and followed for up to 3 years. And based on analysis of this database, it did show sustained improvements in symptoms, health-related quality of life for up to 3 years. Specifically, patients treated with dupilumab showed sustained reductions in EASI through month 36, and that's a measure of atopic dermatitis disease severity. And it did show meaningful improvements in quality of life and itch score as well. I also do want to highlight the Liberty AD OLE study, and this included patients who previously included in a parent study for atopic dermatitis. And this included patients who reached up to 5 years of follow-up. And among that population, the patients who had an EASI 75, so 75% improvement in their symptoms was 88.9%, and the proportion who achieved a 4-point reduction in the PP-NRS score, so a measure of itch, was 66.5%. Also, just want to touch on the guidelines. So in the 2023 American Academy of Dermatology guidelines, they do recommend dupilumab for moderate to severe AD. I do want to note that the guideline authors stated that dupilumab has an excellent safety track track record in clinical trials and few major emergent safety concerns after more than 5 years of clinical practice. And also among a survey of the guideline work group members, all participants did favor dupilumab as their first-line systemic agent. The previous speaker noted there is a new 2025 targeted update. Then again, just want to thank everyone for the opportunity to comment, and I'm happy to provide additional references or documents if needed.
Thank you so much. We appreciate that. Any questions for Kevin? Thank you so much. And so now we'll move on to Scott Kern with Eli Lilly.
You hear me okay?
Yes, I can hear you.
Fantastic. Thank you so much. Well, good morning, all. My name is Scott Kern, as Luis said. I'm a health outcomes liaison with Eli Lilly and Company. I'll be providing testimony, as was noted, on lebrikizumab, which is commercially known as Ebglyss. Now, lebrikizumab is an IL-13 antagonist indicated for the treatment of adults and pediatric patients who are 12 years of age and older, who weigh at least 40 kilograms with moderate to severe atopic dermatitis, whose disease is not adequately controlled with topical prescription therapies or when those therapies are considered unadvisable. Lebrikizumab can be used as either monotherapy or in combination with topical corticosteroids. Has a half-life of 24.5 days with a strong binding affinity and a slow dissociation rate. I know that we've heard comments regarding mechanisms of action, and certainly IL-13 is a predominant target for atopic dermatitis. I think it's interesting to note that all these drugs that we're hearing about, even those that are considered IL-13 antagonists, do have varying mechanisms of action when you get to the specific receptors. Now, the recommended dosage of lebrikizumab is an initial starting dose of 500 milligrams that's administered as 250 milligram subcutaneous injections at week 0 and 2, followed by 250 milligrams every 2 weeks until week 16 or later when adequate clinical response is achieved. The maintenance dose is 250 milligrams every 4 weeks, which in our clinical studies and evaluations for those who responded by week 16 amounts to 13 injections per year during the maintenance phase. The safety and efficacy of lebrikizumab were studied in multiple clinical trials, including the randomized double-blind placebo-controlled phase 3 studies, Advocate 1 and Advocate 2, which were replicate studies, and Adhere. Advocate 1 and 2 were monotherapy studies, while Adhere studied lebrikizumab in combination with topical corticosteroids. We also have Adapt, which is in those patients who have been previously exposed to dupilumab. When we look at the long-term extension study now going out to 3 years, which is known as a JOIN, we see the continued efficacy maintained over time. As was noted, again, the American Academy of Dermatology recently provided an update to the guidelines of care management for atopic dermatitis in adults. And as others have noted about their particular molecules, lebrikizumab also received a strong recommendation by this work group. Please note, lebrikizumab is not an immunosuppressant or steroid. It does not require additional lab monitoring or blood work and does not have a boxed warning. Prior to treatment with lebrikizumab, all age-appropriate vaccinations should be completed. The most common adverse events impacting more than 1% of subjects in clinical trials included conjunctivitis, injection site reactions, and herpes zoster.
And
Please
that's
consult the
time.
full prescribing
Thank you.
information. Thank you.
All right. Any questions for Scott? Thank you. And now we'll move on to our final public comment by Jeff Martin, pharmacist with BioCryst.
Good morning. My name is Jeff Martin, and I am with BioCryst Medical Affairs. Thank you for the opportunity to provide information on Orladeyo or berotralstat for hereditary angioedema, long-term prophylaxis, or LTP. All dosing and safety information can be found at orladeyohcp.com. The World Allergy Organization and European Academy for Allergy and Clinical Immunology published treatment guidelines for the management of HAE that recommend berotralstat should be considered as a first-line option for long-term prophylaxis. The Cochrane collaboration in its indirect treatment comparison has also recommended berotralstat as a first-line therapy option and concluded that there is not enough data available to give preference to any of the other options for long-term prophylaxis. Recently published berotralstat studies have shown a 90.8% reduction in monthly attack rates at 24 months of treatment, as well as reductions in healthcare resource utilization, including hospitalizations, outpatient and ED visits, and on-demand medication use. Berotralstat has demonstrated improved treatment satisfaction as well as improved quality of life. It is the only LTP agent that has demonstrated efficacy in all three types of HAE, including types 1 and 2, as well as HAE with normal C1 inhibitor. BioCryst recently shared a press release regarding the FDA acceptance of their NDA or new drug application for an oral granule formulation for use in pediatric patients with HAE ages 2 to 11. It was given a priority review status by the FDA with an expected PDUFA date of December 12th of this year. In conclusion, I'm respectfully requesting that this committee continue to give Orladeyo at least a parity position without any requirements for use outside of the package label due to its being the only orally available LTP, as well as demonstrated safety, efficacy, improvements in quality of life, and reduction in healthcare resource utilization. Thank you for your time, and I'm happy to answer any questions you may have.
We appreciate your comment, Jeff. And any questions from the board for Dr. Martin? Okay, hearing none, we're moving on to item 4 on the agenda, which is the prior authorization review criteria with the board. And we have 6 PA that we would like to review, but we'll probably not have enough time today. But anyway, we will get started first with Dr. Ashley Park presenting on monoclonal antibodies for atopic dermatitis. And I will stop sharing my screen.
Great. Good morning, everybody. I'll be presenting monoclonal antibodies for atopic dermatitis. These are for Adbry, Dupixent, Ebglyss, and Nemluvio. So the first one is, does a patient have a documented diagnosis of atopic dermatitis with involvement estimated to be greater or equal to 10% of the body surface area, or less than 10% of the BSA with atopic dermatitis involvement to face, eyes, eyelids, skin folds, and or genitalia, and investigator global score of 3 or greater. Is the medication being prescribed by or in consultation with dermatologist, allergist, immunologist, or provider specializing in the disease treatment? Has the member tried and failed at least one medium to super high potency topical corticosteroid and a topical calcineurin inhibitor at a minimum of 4 weeks? Does the provider attest the patient will not have concurrent use with another biologic immunomodulator, JAK inhibitor, or PDE4 inhibitor? Does the provider attest to prescribing the appropriate dose based on indication and patient's weight? Does the patient meet the minimum age requirements based on the FDA-approved indication of the medication? And for reauthorization criteria, has the provider submitted an updated letter of medical necessity or updated chart notes demonstrating the patient has had a positive clinical response, including reduced BSA involvement and IGA score reduction? Does the provider attest the patient does not have concurrent use with another biologic immunomodulator, JAK inhibitor, or PDE4 inhibitor? Okay, any questions about this one? Yes, Dr. Smith?
Hi, good morning. I was wondering about the the choice of, sorry, trying to come up with the word here, the scoring tool, I guess. Because it looks like that's more of a clinical trial scoring tool as opposed to something used in clinical practice. Does anyone know what is used that has more kind of widespread use in practice? Sorry, I'm struggling with this one a little bit because this criteria you're presenting is not the same as the one emailed to us.
Yes, and that's my bad. I failed to email the updated form. But this is the most updated form that we came up with.
I know, it just doesn't give us a lot of time to review what was in here.
Noted. I just wanted to ask Iris, Dr. Juan, if she can comment on this investigator global score. I believe that this one is recommended to be used clinically, and it is a simple guide to be able to rate the severity. Is that right?
Yes, the additional of the IGA score requirement was suggested by our managed care partners. I did actually have a question for providers if they see this as like a common like score to be assessed during their visits with their patients, but I just want to add it on there and see what the thoughts are.
Yeah, so I put the IGA scoring chart here. So the score 3 or 4, these are moderate to severe, and then they're calculated by the severity. Okay. Yes, Dr. Smith.
I mean, one part of, or a big part of atopic dermatitis is the effects on sleep and quality of life, and none of this score factors that in. Just quick look of Dynamed, like poem score, like things like that, has a little bit more more factors included. Sleeplessness, I think, is something that needs to be considered for, especially for kids. Can affect learning and things like that.
Yeah, that's a really great point. And Dr. Breeden?
I was just looking at our criteria, and we have listed just a rating of moderate to severe by the prescriber. So alternatively, we could just substitute the score with a more qualitative assessment by the provider. It's not ideal. I mean, you always want to have something more concrete, but it's an alternative.
Thank you for your suggestions.
And sorry, I can't see how to raise my hand. This is Jennifer Brinton. My screen is taking that part away from me. But I would agree with that too. I don't know if we should need to come up with language right now for that. That'd be great. Again, something that would encompass the symptoms we're treating for the children in a way that's easy to, assess by the clinician.
All right. Thank you, Dr. Benton, for that comment. Can I get a motion from the board to approve the PA criteria with a modification to criteria number 1 to be more of an attestation by the provider regarding the severity of the atopic dermatitis rather than the scale listed there.
So move.
Thank you.
I would second if it says moderate to severe. Yes.
Thank you, Dr. Britton. Any opposed? Any abstentions? All right, thank you so much. And next, I would like to present the criteria for prophylactic treatment of hereditary angioedema. And there, in parentheses, you can see the names of the products that are included in this PA. And no matter how much I practice, I couldn't pronounce all of them correctly. So if you can just see what they are there. All right. Criteria 1, does the patient have a diagnosis of hereditary angioedema, HAE type 1, 2, or type HAE NLC1 inhibitor, INH? Is the medication being prescribed by a board-certified immunologist or allergist? Is the medication being used for the prophylaxis of angioedema attacks? Does the provider attest that the patient has experienced attacks of severity and or frequency that the patient would clinically benefit from prophylaxis therapy? Is this medication being used concurrently with a medication for the acute treatment of angioedema attacks? Has the provider educated the patients on avoiding HAE triggers? Does the prescriber attest that 2 HAE prophylaxis will not be used concurrently? Is the patient not currently on ACE inhibitors or estrogen-containing oral medications and will not take them concurrently with the requested drug? And then we have additional criteria for specific products, and this is mainly regarding the age based on the label that is approved for. And then, as you can see also for number 13 for danazol, is the patient at least 16 years of age or older? Does the provider attest that the patient of childbearing potential has a negative pregnancy test result prior to medication initiation, and that the patient has been educated to use a non-hormonal method of contraception during therapy? And then the other two are also the age limits based on the package insert prescribing information. For reauthorization, has the patient had an improvement in the severity or duration of attacks as documented in the chart note? Initial authorization up to 6 months, reauthorization up to 1 year. And these are just the black box warnings as listed for danazol. And are there any questions by the board? Okay, hearing none, can I take a motion to approve the criteria as explained today?
This is Laura Britton motion.
Thank you, Dr. Britton. Can I get a second?
This is Dr. Siegfried. I'll second.
Thank you so much, Dr. Siegfried. Okay, so now we'll move on to the PA criteria for Adzynma presented by Iris One, our pharmacist.
Can I ask a point of clarification?
Yes.
So we're taking motions and seconds, but we're not voting anymore on the criteria?
I'm sorry, Dr. Smith. Good point. So we have a second motion there, Dr. Siegfried, first motion by Dr. Britton, and all in favor of approving the criteria as presented today for the prophylaxis of HAE?
Aye.
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 Thank you. And any abstentions?
We also need to vote on the last one.
Okay, thank you so much. And then also for the criteria for the monoclonal antibodies for atopic dermatitis. All in favor
Aye.
of the criteria?
Aye.
Thank you. Any opposed? Any abstentions? Thank you, Dr. Smith. All right, now we give the time to Dr. Juan for Adenzima.
Good morning, everyone. Can they see my screen?
Yes.
Okay, great. So I've had SIMA. The first criteria is, does the patient have a diagnosis of congenital thrombotic thrombocytopenia purpura or CTTP with 8MTS13 or 80AMTS13 mutation as confirmed by genetic testing? Is the medication being prescribed by or in consultation with a provider specializing in the treatment of CTTP, such as hematologist or oncologist? Is the medication being prescribed for one of the following: acute exacerbation, prophylaxis for symptomatic patients, prophylaxis for asymptomatic pregnant patients with a due date, and then single prophylactic dose for patients undergoing a procedure or who are acutely ill and have been hospitalized? Does the patient have ADA-MTS13 activity of less than 10%? Has the patient tried and failed or has a contraindication to plasma infusions? Would the provider be adhering to the approved dosing outlined below? And then we have a chart for each indication. And for the reauthorization criteria, has the patient had a reduction in acute exacerbation or subacute events? For example, thrombocytopenia, increase in lactate dehydrogenase. Then the authorization period according to each indication. And are there any questions or concerns?
Okay, sorry, I can't raise my hand at all. The level of under 10%, I don't know. I wish I were a hematologist. Do any of you know if that's something that's routinely looked at and if that's clinically significant? I know sometimes we have these numbers that are very clinically significant, and other times they might not need to be there. Anyone have any insight into that? I'm sorry that I don't have that. That would be 0.4 on the criteria. Otherwise, I feel like it looks like a pretty benign, it doesn't look like a big barrier. You're using it for the purposes it's intended. It looks like a wide range of purposes. The reauthorization seems to be appropriate. So I would be in favor of this otherwise, but.
Yes, Dr. Britton.
I just wanted to mention, I'm not an expert at all, but the labeling in the drug reference, it says each file is labeled with activity of that ADAMS-AMTS13. So that activity appears to be something that is measured.
Thank you.
Then I'd be in favor of approving this prior auth as a motion.
Thank you, Dr. Brinton.
I can second that.
All right, thank you so much. And all in favor of approving the criteria as presented?
Aye.
Thank you. And any opposed or abstentions? All right, thank you so much. Moving on with Dr. Fenton presenting on Cabenuva.
Good morning. Let me just get this screen shared here. Alrighty, so Cabenuva or Caplazizumab. The criteria for approval, number one is the patient 18 years of age or older, Does the patient have a diagnosis of acquired thrombotic thrombocytopenic purpura, ATTP? 3, does the provider attest to ruling out secondary causes of thrombocytopenia, such as congenital thrombotic thrombocytopenia purpura, hemolytic uremic syndrome, and drug-induced thrombocytopenia? 4, is the medication being prescribed by or in consultation with a provider specializing in the treatment of ATTP? 5, will the medication be used in combination with plasma exchange and at least one immunosuppressive therapy? 6, did the patient have an ADAM-TS13 activity of less than 10% upon inpatient admission? And 7, did the patient have one of the following upon inpatient admission: neurologic abnormalities, decreased level of consciousness, or elevated serum troponin level? 8, has the medication been administered upon inpatient initiation of plasma exchange therapy? And that's the criteria. There's an initial authorization of up to 2 months after the anticipated start date, and nothing on reauthorization. Does the board have any questions?
Okay, hearing none, can I get a motion to approve the criteria as presented? Oh, Dr. Smith?
My understanding is this is used in like emergency situations, often when they don't have the ADAM TS13 activity level available. And so I guess I just am concerned that that could be a barrier to treatment, because they might get it later they might be able to get the results later in the hospitalization, but not before needing to use this therapy. Does that make sense?
Yeah, that makes sense. You don't want to put too many barriers if time is of the essence.
So I would say either strike number 6 or put a caveat like if able to obtain.
Yeah, I'd second that motion. Thank you.
Thank you for the motion. So we'll go ahead and follow with the motion to approve the criteria as presented, except for number 6 regarding the ADAM TS13 activity, to either get rid of it or mention that it is, if it's available, to make it optional for the provider if it's available. And I have 2 motions, and then all in favor?
Aye.
Any opposed?
I would be in favor if we keep it and just say optional.
Thank you, Dr. Brinton. Any abstentions? All right, motion passes to approve this with the modification mentioned. Thank you so much. And now we're moving on to PICRAE, and I will be presenting that one. Okay, so here we go. Is the patient 18 years of age or older? Does the patient have a diagnosis of hormone receptor HR positive human epidermal growth factor receptor 2, HER2 negative, PIK3CA mutated advanced or metastatic breast cancer as detected by an FDA approved test? Is the medication being prescribed by or in consultation with an oncologist? Has the patient tried and failed aromatase inhibitor based treatment as recommended by the NCCN guidelines? Will PICRAE be used in conjunction with fulvestrant as recommended by the NCCN guidelines? Does the provider attest to counseling the patient on the severe adverse effects, and appropriate management. So that's severe cutaneous adverse reaction, hyperglycemia, pneumonitis, diarrhea or colitis, and pancreatitis. And then for the reauthorization, has the patient experienced any disease progression or unacceptable toxicity? And it would be approved up to 6 months. And for initial reauthorization up to 1 year. And that is all. Any questions on the PICRA criteria? Yes, Dr. Smith. Oh, sorry, you're muted.
Thank you. I was wondering about the wording on the reauthorization criteria. So it's saying that they have if they check yes to an unacceptable toxicity, that means it is reauthorized, just based on how this is worded.
Okay, good catch. So we can split that into two to make it just be one or the other, right?
Mm-hmm.
Thank you so much.
Yep.
All right, any other questions? And can I get a motion to approve as amended?
I can mention.
Second.
Thank you, Dr. Britton and Dr. Brenton. And all in favor?
Aye.
Aye.
Thank you. Since there's only 4 of us, or you, then none are opposed, then no abstention. So thank you so much. Motion passes. Wow, we're moving along. So now we're down to our final PA criteria for today. And it is for the product Nudexta. And I will also be presenting that criteria. The Nudexta is dextromethorphan-quinidine combination. Does the patient have a diagnosis of pseudobulbar affect caused by a structural neurologic condition, such as amyotrophic lateral sclerosis, multiple sclerosis, or stroke? Is the medication being prescribed by or in consultation with a neurologist? Has the patient used MAOIs within the past 14 days? Has the patient tried and failed at least 2 of the following medications? So that includes a TCA, SSRI, or SNRI medication. Does the patient have a baseline EKG with no significant abnormalities and no history of QT prolongation syndrome? And has the patient had at least 10 episodes of inappropriate laughing or crying per day before therapy? Reauthorization criteria: has the provider submitted an updated letter or medical necessity or updated chart notes demonstrating the patient has had a positive clinical response? And has the provider submitted documentation showing a 50% decrease in the number of episodes of laughing or crying compared to baseline before Nudexta was started? And it could be authorized up to 3 months initially, and for the authorization, it's up to 1 year. And any questions on this one? Yes, Dr. Smith.
The MAOI inhibitor statement number 3, should it not read has the patient not used MAOIs within the past 14 days? They have
Yes,
to be off the MAOIs for 14 days before starting this.
noted. Yeah, because then that would be, if it's a yes, then it would be approved. Thank you for that.
Mm-hmm.
Any others? Okay, and can I get a motion for approval of the criteria as presented? Oh, Dr. Siegfried. And you're muted, Dr. Siegfried.
Under the reauthorization criteria, it should be a 50% decrease in the number of inappropriate episodes of laughing or crying, to the same as number 6.
Okay. Yes, noted. Thank you so much. All right, that's a good clarification. And yeah, can I get a motion to approve the criteria as presented? And
So
amended?
move.
Thank you, Dr. Benton. Can I get a second?
Second.
Okay, very good. And all in favor?
Aye.
Aye.
Thank you so much. Any opposed or abstentions? And motion passes. Wow, we got six great PAs done today. Thank you so much for your help. And our next meeting is scheduled to be October 9th, and the topic will be concomitant use of oral buprenorphine containing products with full agonist opioids and the use of oral buprenorphine containing products other than Belbuca for pain. And can I get a motion to adjourn?
So move.
Thank you, Dr. Smith. Can I get a second?
Second.
Thank you, Dr. Benton, Dr. Britton. All right, everyone. Have a good rest of your day. Thank you for coming.
Thank you.
Thank you.